Comprehensive Addiction Diagnostics, applying a risk-stratifying chronic illness model to SUD assessment, prevention, and treatment. Hi, I'm Calvin. I'm presenting today from Chicago. Thanks for joining us from wherever and whenever you may be just now. Most likely you're safe at home too, during this pivotal 100-year moment in our collective human journey, which reminds me of a story about getting home that many of us have cherished since childhood. Once upon a time, a little girl named Dorothy got caught up in a tornado. And all she wanted to do was get home. Because there's no place like home, right? Unless, of course, you're forced to be there for weeks or months on end. But Dorothy was lost in another world, with an emerald city and a wonderful Wizard of Oz who could get her home. She just needed to follow the yellow brick road. Today we're going to take a closer look at Dorothy's yellow brick road and see what it's really made of, so we can reconnect and better align two critical addiction medicine gaps. First, the disconnect between substance use disorders and every other chronic condition. Secondly, the long-standing gap between our assessment and treatment methods and our sustained remissions. And hopefully, while doing so, we'll notice the role of stigma in limiting how much we apply what we've known for decades to the kind of addiction care we give and the more lasting results we're after. Full disclosure, Calvin McGinn is the co-founder of Compris, Inc., a for-profit online addiction assessment and research firm seeking partnerships to study and inform sustained remissions. Okay, back to our objectives. First question. Do you think there's a disconnect in how we see and manage addictions versus other chronic conditions? While you ponder that, listen to the American Society of Addiction Medicine's answer to the question, what is addiction? Addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. The definition concludes with the following. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. A JAMA article published in 2000 reported comparable 40 to 60% one-year substance addiction remission rates to those with diabetes, hypertension, and asthma, in line with ASAM's statement here. However, a more recent 2016 15-year review of 8,855 studies, of which 21 qualified based on 3-year minimum follow-ups or lifetime remission outcomes, was far less encouraging. There, the researchers reported something under 10% pooled substance disorder remission rates in any given year, plus an average of 17 years to achieve 50% remission rates. Their results aren't even close to comparable treatment success with other chronic conditions, especially given how many more illness years it took on average to match other chronic illness remission rates. So why such an outcome gap between substance addictions and other chronic illnesses? Well, either we're dealing with a much tougher chronic illness to manage, or we just haven't found or applied the kinds of tools and evidence other chronic illnesses routinely implement as standard of care. There's very little evidence of targeted, risk-based prevention prior to the onset of substance misuse. The Substance Use Risk Profile Scale, SERPS, is one notable exception. This slide illustrates the wide gap in quantified, risk-based care of those with addictions versus diabetes, cancer, and heart disease, as well as the insidious role of stigma and bias. The prevention options available for every other chronic condition rest on quantifiable risk factors that help predict that illness's onset, likely severity, and how hard it will be likely for that person to manage their illness. This is how we motivate lifestyle adjustments early on. The far right column tells the story of addictions. We can't prevent what we can't see coming, plain and simple. Which means we've got to quantify the risk that offers that foresight. The medication we choose, the treatments we offer, and the sustained outcomes we seek, like any other chronic condition, either match a person's quantifiable risk profile or they become a one-size-fits-all, or require very seasoned clinicians to match with any consistency. We aren't even on the same page about harm reduction, something well understood for every other chronic condition. What would it look like if our prevention, assessment, treatment, attitudes, and long-term care of substance addictions was as committed to bringing quantified, evidence-based risk factors to our routine practices as is already the norm for every other chronic condition we treat? Maybe that's how we put a dent in the remission gap between them. So what's SUD's Yellow Brick Road? And what's it made of? Well, unless there's a flood or earthquake to split it open, we're used to seeing just the surface of roads, right? For a substance disorder, let's say that visible surface layer represents its acute 30-day episodic severity based on, for example, how many DSM-5 symptoms are currently present. Nearly all our assessments and outcomes prioritize this main driver of what we do and whether it works. Unfortunately, most of what is needed to fully assess, prevent, target our interventions, and sustain their outcomes beyond a few weeks to months actually lies below the surface and must be dug up. The deepest layer of SUD's Yellow Brick Road reveals all the evidence-based risk factors we've known for years that can help predict who's likely to both get this illness and have a tough time managing it. Things like relatives with addictions, comorbid illnesses like depression or bipolar, the impact of early and multiple substance use on the developing brain, user traits like impulsive and sensation-seeking behavior, a whole range of PTSD contributing life traumas, as well as continuing to use despite damaging consequences. The middle layer actually holds the most important key to illness management: evidence-based resilience resources or recovery capital that help manage everything else life throws at us, including a substance use illness. To rebuild this three-layered road, we need to remind ourselves what's at stake if we don't get it right. The two closest signposts are the most likely outcomes if we don't. When factoring in the comorbid impact of addictions on every other chronic condition, a distant emerald city of sustained remissions gets even further away for those using one illness to manage another. Would you like to see what the rebuild actually looks like? This slide shows what the foundation looks like once key risk factors are identified, quantified, and ranked. For example, substance-specific risk tied to negative thinking, anxious feelings, and impulsive or sensation-seeking behaviors play an increased role compared to other user traits if scored one or more standard deviations above the norm. Low risk, at risk, and at significant risk distinctions can then factor into prevention and treatment plan recommendations. Each risk factor is assigned a weighted score and ranking compared to others, from a detailed history that sorts life experiences into one of the BUILD model's 5 evidence-based risk factors, all shown here. This is one of my favorite slides because it shows the relationship between enduring risk and mediating resilience. The importance of measuring each of the 4 resiliences here during intake and at 3 to 6 month intervals cannot be overstated, since their conscious development is the only way to bring enduring self-empowerment tools for lifelong rewards that include long-term, successful illness management. The highlighted middle graph displays current risk and resilience levels. The graph above shows how risk is increased when resilience is minimized, and the effect this has on decreasing the likelihood of sustained remission. The bottom graph shows the opposite. Maximize resilience and see risk decrease and sustained remission significantly increase. Because the enduring risk for this patient is already very high, sustaining illness remission will still be a difficult task, no matter how many resilience factors are developed. Notice the kinds of resilience traits that make up each of the 4 resilience types. These come from the evidence-based positive psychology and recovery capital literature, but were grouped to assist in better understanding where both patient strengths and opportunities for growth are most evident. These then factor into the recommended prevention and treatment plans. So what does a comprehensive addiction assessment summary look like? Well, it starts with offering well-informed, risk-stratified information, whose guidance includes the mediating impact of current resilience on lifetime addiction as well as the likelihood of sustained remission. Personality traits, plus any substance-specific risk they carry, are also front and center. In the context of a chronic illness model, risk, resilience, and sustained remission concerns are prioritized without ignoring the impact of illness acuity and severity. For the same reason, Illness expression and severity is tracked across 4 time periods for each of 4 addictive substances. To the right are the components of engagement: subjective severity, illness denial, and current motivation to be in recovery. Comparing subjective versus objective illness severity, plus the amount of damage from use, helps clarify the extent of any denial present. The motivation scale offers more quantifiable understanding of the level of motivated engagement and inner conversation that currently occupy the patient's focus. It takes the stages of change conversation to a more practical level of collaboration, mutual learning, and next steps. The clinical rewards for having dug so deeply into our 3-layered yellow brick road include a much wider range of prevention and treatment guidance illustrated here. The quantified interactions of risk, resilience, and illness severity enable a clearer picture of prevention strategies, withdrawal management, level of care placement, medication selection, group selection as well, and minimum duration of each, as well as patient preferences. Only an assessment tool designed from a chronic illness paradigm would deliver this level of robust specificity and informed continuity of care. Everything shared today is about road rebuilding research that helps achieve greater chronic illness parity through sustained SUD remissions. To that end, we've created a 10 to 20 minute online tool that delivers instant results to providers similar to what was shared today and based on 20,000 interacting algorithms. We've also partnered with the University of Cincinnati School of Criminal Justice and are also launching a 60-day pilot with whoever would like to join us in exploring the value of bringing more robust SUD assessment and treatment guidance to a wide range of clinical settings. Bring any questions or comments to the Q&A time slot or email, text, or visit our website. Thanks again for being here. Bye-bye.